Okay, so the last thing we covered in lecture class was that we saw how T3 and T4 are produced and then how they are released back into the bloodstream. So if we look at what initially makes T3 and T4 be produced, we've actually talked about this. That's that one chart that I said that has the one tier or first tier, second tier, third tier for all of the glands of the anterior pituitary. So definitely study that, but we can review it. So what we have here, first tier, which means this is the first thing that has to be produced for the ultimate goal, which in this case is to produce T3 and T4. Okay, so we know that T3 and T4 are made by the thyroid gland. Okay, so if we want to stimulate the thyroid gland, we have to make a hormone that tells it to do that. So we have thyroid stimulating hormone. Thyroid stimulating hormone, of course, is our second tier, okay? But the anterior pituitary only produces and releases this when the first tier, which is our hypothalamus, tells it to, and it tells it to by thyrotropin releasing hormone. Okay, so your first tier is the hypothalamus. That triggers the anterior pituitary to make TSH, which triggers the thyroid gland, which is an endocrine gland, okay, which is why TSH is a tropic gland, to make the two hormones T3 and T4. Okay, T3 and T4, technically they're not the same. Remember, 4 indicates, the numbers basically indicate how many iodines are attached. So T4 has 4, T3 obviously has 3. A lot of target tissues, more target tissues actually use T3 than they do T4. However, the thyroid gland actually makes more T4, which you might think is weird. Why would it make something if it's just going to go back and convert it? Well, the reason is T4 lasts much longer in the blood than T3, so it lasts longer, therefore it's a reservoir. Okay, so wherever we have T4, it can very quickly be converted to T3 in peripheral tissues versus having to stimulate the thyroid gland to make more T3 in the first place. Okay, so we also see regulation. So what's going to make TRH initially be produced, which we know is actually going to increase T3 and T4 production when those are much lower than what they should be. So when you're not making enough thyroid hormone, your metabolism's too low, or if you're exposed to very cold temperatures. Where cold temperatures, we have to heat up the body. So of course you have a lot of shivering. That takes a lot of ATP, which means you need to increase metabolism. So of course to inhibit them, we would have the opposite. So if your T3 and T4 are high, then you're going to trigger the anterior pituitary to stop releasing TSH. So we would actually make a hormone called somatostatin, which is actually growth hormone inhibiting hormone. So if you're not growing a lot of tissues, you're not going to need to have a high metabolism. Okay, so that's why you see the link there. Okay, so again, this kind of is what I was showing earlier, showing the effects. Again, make sure that you understand this. You understand how the negative feedback works. You know exactly what causes the stimulus to be produced, what are the effects, everything and anything in between. You will have to know all components of this. Okay, so make sure that you know these steps and you understand. Okay, thyroid disorders are when you have an imbalance due to systemic effects of thyroid hormones. Why it's systemic is because thyroid hormone basically triggers almost every cell of the body. So again, as I said in class, hyper is too much. So hyperthyroidism, you're going to have too much thyroid hormone being produced. Hypo is going to be too little. So if your metabolism is really, really high, you're basically burning those fuel molecules as food and converting to ATP. So you're going to be losing a lot of weight. If your metabolism's already high, your body's going to be kept at a high temperature. So if you're exposed to heat, it's going to be really hard to cool you down. It can mess up your blood pressure and your heart. So metabolism in every cell of the body. Okay, so you're increasing the activity of your heart, which therefore increases blood pressure. So basically, you could be overexerting the heart. Also, you are basically overstimulating, the thyroid gland. So that's why the thyroid gland will actually get very large and develop this large mass, what we call a goiter. A lot of times, too, associated with that, you'll notice they're showing here in the picture how you have bulging eyes in someone that has hyperthyroidism as well. One of the most common causes of hyperthyroidism is actually what we call Graves' disease. It is an autoimmune disease in that you make proteins that are very close to TSH. So basically, you're constantly stimulating the thyroid gland, even though the hypothalamus and pituitary gland aren't the ones doing it. So it's like a false stimulation. Okay, so the opposite of hyper, too much, hypo. So basically, you're going to see the opposite symptoms here. Your metabolism is too low, so you don't need as much food to keep your body moving. So typically, people will gain weight. They're going to have an intolerance to cold because it's hard for them to increase the metabolism to allow the muscles to contract enough to shiver. Their heart's going to be slowed. Low blood pressure, again, those are opposite. Your body tissues aren't working as much. They're not going to need as much blood. Definitely will not have a goiter. It can be due to an immune disorder that somehow you're attacking the thyroid gland, not allowing it to produce. Sometimes, actually, it also can be that there might be a tumor on the pituitary gland, where the pituitary gland can't produce TSH. And of course, if you can't make TSH, then that means you cannot make T3 and T4, okay, which of course are our thyroid hormones. Or if you don't have enough iodine in your diet. Remember, one of the first steps in making T3 and T4 is that we bring iodine from the blood into our cells and we actually convert it to iodide. The other form of hypothyroidism is in babies. You're born with it, so that's what congenital means. We also call it creatinism. So in the baby, when you don't have enough thyroid hormone being produced, it does help the normal development, remember, of nervous, skeletal, and muscular systems. And so you're going to see a delayed response. And if you don't fix it, as that continues to go, you will have basically a reduced neurological condition. So you'll have some mental retardation. The person's not going to be able to develop the brain quite properly. Okay, so this is a condition clearly showing this poor woman that has this large mass, okay, a goiter created from an enlarged thyroid. Question is, why is endemic goiter uncommon in the U.S.? Because typically if it's an issue with TH being produced, you can be medicated for that. But more importantly, in some countries, they do not have the ability to get iodine. It's not in the soil, they don't have it in the water, and they don't have availability to marine foods. Okay, so therefore they can't make T3 and T4, so of course they have an overproduction of the TH, which creates the goiter. Okay, so again, to understand the negative feedback between thyroid function, so when T3 and T4 levels drop, Okay, the receptor cells in the hypothalamus detect the change. So how is this proving a negative feedback? We have T3 and T4 dropping. I'm just going to write TH. Okay, hypothalamus detects that, and it's going to make more TRH, which stimulates the anterior pituitary to make more TSH, which is going to stimulate the thyroid gland to make more thyroid hormone, including T3 and T4. So basically, not only are you making more T3 and T4, but you're going to be releasing at a quicker rate as well. When they get too high, then of course you're going to, stop the production of TSH. Okay, primary hypothyroidism. The problem is you cannot make more T3 or T4, thyroid hormone. However, the hypothalamus and thyroid gland does not know that T3 and T4 is not being able to made. Therefore, they still sense they're low, so they will continue to make more TRH and TSH. So that's basically one way they can test to see if you have primary hypothyroidism, if the amounts of TRH and TSH are high and T3 and T4 are low. Secondary hypothyroidism involves pituitary dysfunction. So what that means is pituitary is what makes TSH. Okay, so if something's wrong with pituitary, it cannot make TSH. Therefore, T3 and T4 will also be low. Okay, so secondary, the difference is TSH is low, where in primary, TSH was high. Okay, now we're looking at primary hyperthyroidism, not hypo. So remember, hyper is the opposite. So under normal conditions, again, if you have too much being produced, then you're going to tell, the hypothalamus is going to basically tell the anterior to stop making TSH. So it will stop making TRH. You stop making TSH when you have too much T3 and T4. So in hyperthyroidism, of course, the hormone levels are extremely elevated. So your receptors in your hypothalamus will sense this, and the production of TRH and TSH fall to nearly zero, which that's a problem. You want those to be constantly being released a little bit at all times. Thyroid hormone is actually one of the hormones that our body keeps a decent amount in supply stored in the gland because it's so important in regulating every cell in the body by increasing metabolism. Okay, so if we actually did the lab report, we do it over Endocrine, and this is actually something that we look at. An ectomy of anything is when you remove the thyroid gland. Okay, so if the thyroid gland has been removed, obviously the thyroid makes T3 and T4. So if you don't have the thyroid gland, you cannot make T3 and T4. So the hypothalamus is going to sense that T3 and T4 are low. It's going to make thyrotropin releasing hormone, which is going to go to the anterior pituitary making TSH. Okay, but TSH does not have anything to stimulate. Okay, now we're going to focus on the other hormone made by the thyroid gland, which is calcitonin. And why calcitonin is next to parathyroid are these two hormones are antagonistic of one another. So they have opposite effects. Okay, so both of these basically are going to help regulate the levels of calcium ions in the blood. So the parathyroid gland makes PTH. Specifically, the cells in the parathyroid that do that are called sheath cells. Okay, so they make PTH. Thyroid secretes the other calcium regulating hormone, which is calcitonin. Okay, again, opposing effects, antagonistic. Okay, so let's talk about parathyroid hormone first. This one is actually more important in maintaining blood calcium than calcitonin is, so it's a more major factor. It's made or released when blood calcium levels are too low in the blood. Okay, so if it's too low in the blood, remember calcium is necessary for all types of muscle to contract, for nerve impulses to be sent. And so it's more important that we have calcium for those activities than to help bone to stay strong. And bone is one of the major places where we store calcium, is calcium carbonate. So basically what PTH is going to do, it's going to stimulate the cells of the bone. Y'all should remember this from AMP1, osteoclast, break down, they cleave parts of the bone, breaking it down, dissolving it, releasing more calcium in the blood. Also, we're going to increase how much calcium that we are reabsorbing in the small intestines. What we're also going to do is something that helps us be able to increase more calcium ions is vitamin D. And so the kidneys are going to work on activating the vitamin D. Basically, from dietary, any dietary ways that you get vitamin D. We also get vitamin D from as light hits our skin. The kidneys are going to convert it, it's calciferol in its inactive form, to calcitriol. And calcitriol allows us to increase calcium absorption. We're also going to increase any calcium ions that are in the kidneys. So if we reabsorb them, we are, once again, returning to the blood. Okay, so it's going to do all three of these things to help increase calcium levels in the blood. Okay, so clearly this is a negative feedback loop. So the levels got too low. So in the parathyroid gland, here it's the chief cells, okay, that detect the low blood calcium levels. And again, we're checking something in blood. So this is going to be a type of humoral stimulus. Control center, brain's basically going to tell the chief cells to release more PTH. And the response of that, of course, is that we're going to increase the amount of calcium in the blood until it returns back to its normal range. Okay, as soon as it's back to normal, then of course you're going to tell the chief cells to basically stop making PTH. So the hormone that's antagonistic, calcitonin. Okay, calcitonin is made by parafollicular or C cells, which are in between the cells that make up the follicles in the thyroid. Okay, again, so if we can kind of visualize this, these follicular cells are what make T3 and T4. Parafollicular, the cells between the follicles. Okay, so you'd have follicles all around here, and again, those make calcitonin. So basically, this is going to do the opposite. So when are we going to release calcium? This time when calcium blood levels are too high. Okay, so the opposite stimulus is going to trigger the response. And this one, you really have one primary target, which of course is why PTH is the more major regulator, because its target is several different organs. So osteoclast, now we are going to stop the activity of osteoclast. So as we stop breaking down bone, this allows natural osteoblast activity that's already occurring to continue to build bone. And of course, to build bone, we're going to add calcium to it. Okay, so this is just the table that helps summarize the effects, the target tissues, the stimulus. Again, make sure you know all of these components and you understand the order. Okay, so a problem that we can have with not having enough calcium in the bones is osteoporosis. And know we've talked about this in AMP1. So if you have osteoporosis, you want to increase the amount of calcium that's in your blood so you can store more in bone. Okay, because obviously the more brittle the bones are, the easier it's going to be for them to fracture or break. So we're going to give them, basically you can do two different things, or they can do in conjunction. Calcitonin can be administered. A lot of times they'll do this as a nasal spray to get it in the bloodstream pretty quickly. And this is going to increase bone mass by slowing those osteoclasts and therefore, again, allowing the osteoblasts to work. Okay, a drug that acts like PTH mimics, basically would be able to bind to the same receptors, is going to do, it's going to do the opposite response, counterintuitive. So we really don't want that to happen. And just an important note here, so if you don't have an abnormality, if calcium levels are normal, PTH will actually increase calcium concentration by reabsorption in the small intestines and the kidney, but it's not going to stimulate osteoclasts. So you're not going to have the extra breakdown of bone. Okay, so for reviewing information about the thyroid gland, which of these hormones would increase in a laboratory animal after a thyroidectomy? We already talked about this. So the thyroid gland has been removed, which means they can't make T3 and T4. However, the hypothalamus does not understand that that's why T3 and T4 are so low. So it's going to make its TRH, which is going to make the anterior pituitary release TSH. Okay, you cannot make triiodothyronine or thyroxine, okay, without having a thyroid gland. So the correct answer here should be E. Okay, T3 and T4 are water soluble and therefore they cannot diffuse through the plasma membrane bilayer. That's false. If you remember, thyroid hormone is the one exception of an amino acid derived hormone that is hydrophobic. Sorry, I did not spell that right. Hydrophobic, which means that it's not water soluble. And thyroid T3 and T4, remember, are going to affect the nucleus. So they have to be able to get through the plasma membrane. Okay, which of the following is an effect of the thyroid hormone? It has nothing to do with blood cholesterol, so that would be incorrect. Has nothing to do with the production of carbohydrate. Skipping C for right now. It has nothing to do with epinephrine and norepinephrine. That's the adrenal medulla. Body growth is primarily growth hormone. Remember, TH can affect that as well. TH, though, increases metabolism, which would increase body growth. So because this is slow, this cannot be correct. If you have increased rate of metabolism, that means you're going to need more oxygen to undergo those reactions. So that's why C is the correct answer. Okay, so what is not a function of the parathyroid gland? Well, let's think about what the parathyroid glands do. Okay, they make parathyroid hormone, which increases blood calcium levels. Okay, so to have more calcium in the blood, what makes it easier to absorb the calcium is going to be vitamin D. So yes, we would want to increase the formation. Remember, we're going to increase the kidneys, activating it to the form of calcitriol. Of course, the major thing it does regulate blood calcium levels. It does increase bone reabsorption by stimulating osteoclasts, stimulating activity, not by increasing the number of cells. It increases activity, which of course is why B is the incorrect information. So by Increasing vitamin D, the active form is calcitriol, so that's why that one would be true as well. Okay, still looking at blood calcium here. We're looking at how parathyroid hormone and calcitriol play together. So again, we're saying what's not true. So calcitriol, which is active vitamin D, increases calcium absorption. Yes, it absolutely does that. We already mentioned PTH, its primary function is to increase blood calcium, so it does reabsorb more bone to do this, so that's true. High blood calcium levels increase calcitonin release. That is true. Remember, calcitonin has the opposite effects of PTH. So if PTH is triggered or stimulated by low blood calcium, calcitonin would be high. PTH would not decrease vitamin D levels, it would increase vitamin D levels. And of course, PTH does raise calcium levels in the blood by stimulating osteoclast activity, increasing the amount absorbed in the small intestines, and increasing the absorption in the kidneys. Okay, now we're going to discuss the adrenal glands. Okay, so adrenal glands are located just above each one of our kidneys. I just drew the right one. They're a pyramid shape, and they make two different things depending on which part. So it's divided into two different areas that are not only made of different tissues, but they, of course, release different things. So the most outside portion, okay, between the two areas of blue here, the outer portion, we call that the cortex. And of course, you need to be specific in lab and say adrenal cortex because there are other cortices in the body by other organs, including the cerebral cortex, the cerebellar cortex. So make sure you're really specific. The cortex is typical endocrine gland. So what that means is it's going to secrete, make, and release hormones. The medulla is neuroendocrine. Okay, so it's going to secrete what we call neurohormones. Basically, these are modified sympathetic ganglion axons that are actually going to secrete and release epinephrine and norepinephrine. So what other gland has one part being endocrine, one part being nervous? That's going to be the pituitary. Okay, if you look at the pituitary, remember the anterior secretes, produces, releases its own hormones. So that's like the cortex. The posterior just stores them, okay, and it has axon control from the hypothalamus. So the pituitary gland is what's similar. Okay, so the cortex we can further divide into three zones. Each one basically produces a specific type of corticosteroid. Okay, so the outermost layer, zona glomerulosa, makes mineralocorticoids. Middle, zona fasciculata, makes glucocorticoids. And the zona reticularis makes glucocorticoids. The same as the zona fasciculata, but it also can make androgenic steroids, so sex hormones. Okay, so the three distinct layers, one thing that I do to help me remember, this is externalmost, this is internalmost, innermost, so that's of course where the medulla would be, so it's going to be glomerulosa, fasciculata, reticularis. Okay, so GFR in that order. And again, it is mineralocorticoids, glucocorticoids, gluco, and then the androgens. And then, of course, the medulla is going to be your epinephrine and norepinephrine. Okay, so this is regulated partially by that multi-tiered negative feedback loop that we discussed. We discussed in lecture. That's going to be figure 16.8. 16.8, and that's on page 597. Okay, so you can review that. We call it the hypothalamic pituitary adrenal cortex axis. Obviously, the H is for the hypothalamus, P is for pituitary, and A is for the adrenal, specifically cortex. Okay, so the hypothalamus is the first tier. That is going to make corticotropic releasing hormone, okay, which is going to go to the anterior pituitary, which releases adrenocorticotropic hormone, okay, which is therefore then going to stimulate the adrenal cortex. Okay, so if we actually talk about the individual different corticoids that are produced by each zone, we're going to start with the outermost zone and what it produces, which are mineral corticoids. We primarily really just talk about aldosterone with this. Aldosterone is the most important one. Aldosterone helps us regulate minerals, or you call them electrolytes in the body, including minerals or electrolytes in the body, including sodium and potassium, which of course are cations. So it's going to help make sure that the amount of sodium and potassium that we have in the extracellular fluid is within the normal range. Remember, if you change the amount of sodium and potassium across those channels, then you're going to change the ability of muscle cells and neurons to be able to send their messages, because of course they rely on the fact that there's more sodium outside, more potassium inside. So when you depolarize, sodium moves in. When you repolarize, potassium moves out. Okay, so it does this by regulating, again, what's in the extracellular fluid, okay, outside of it. Okay, sodium is commonly found with chloride because that's what salt is. So in the kidneys, when we move salt and sodium, if we can move those back into the fluid, naturally water's going to move through osmosis. Water's going to follow sodium. So we are going to be able to retain more water. Okay, so by changing the amount of water in the body, this allows us to change the amount of blood that we have in the body. If you can change the amount of blood, then you can change the blood pressure. Okay, so the more blood that's present, the higher the blood pressure. So it's able to help regulate blood pressure through a very complex series of interactions, which we short called Ross system. So the R stands for renin, first A, angiotensin, aldosterone system. So what the primary purpose of this system is to increase the amount of blood in the body. Therefore, you have more blood going to the heart. If the heart has more blood, then it's going to be able to pump more blood to other organs of the body, including the brain and the kidneys. It also helps to maintain the acid-base homeostasis, which, remember, our blood, as we talked about in lab, or at least in my lab I did, blood range is 7.4 plus or minus 0.05, so that's a pretty narrow range. It does this by activating hydrogen ion pumps. Okay, so remember, pump means that it's going against the concentration gradient. So we actually already have more hydrogen ions inside. This is the kidney tubule. However, we're still going to force, you have hydrogen outside in the extracellular fluid, even though it's less. We're going to make that hydrogen go through hydrogen pumps, forcing it to go into the kidney tubule, which eventually what's in here becomes urine. So if we're making hydrogen leave the body, we are going to be able to increase the pH of our blood because we're getting rid of acid. So, and again, if you look at blood pH, it is slightly alkaline or basic. Alkaline means same thing as basic. Okay, so here's basically just depicting everything we talked about. These are the different effects of aldosterone. Okay, so it's going to allow sodium and chloride, okay, to go from the kidney tubule back into the blood. That means we're keeping it. Okay, and so if we keep salt, naturally water's going to follow. Okay, water, of course, moves through osmosis. We are also going to excrete, get rid of potassium ions and the hydrogen ions. And those are both going to help with the acid-base balance. We'll discuss more in urinary how potassium helps with this. Right now, we just really focus more on, obviously, how hydrogen leaving is going to raise the pH then in the blood. Okay, so if we look at the different factors that are regulating when we are actually going to make and release aldosterone, first we have elevated blood potassium levels. So when potassium's too high, that's actually going to make your pH be low. Okay, so for us to regulate pH, we would want to release aldosterone, so that would get rid of the potassium in our blood by excreting it into the urine. And then also a hormone, which we call angiotensin II, which is part of this system. So when angiotensin is released, which is one of these steps, we're going to go over the steps in a minute, it's actually going to further increase the more release of aldosterone. So again, we talk about the hypothalamus is for H. So remember, that's going to make, so the hypothalamus makes corticosteroid releasing hormone. The hypothalamus releasing hormones go to the anterior pituitary. So the P is for anterior pituitary, which is then going to make more ACTH, okay, which stimulates more aldosterone. So the third tier here is our adrenal cortex. I'm just going to write cortex for short right there. Especially in stress, you're basically going to increase the system. Why does that make sense? Remember, we said that aldosterone increases the amount of blood. And if you increase the amount of blood, you're increasing blood pressure. When you're stressed, your blood pressure is high. Okay, during stress, your cells are more active, meaning they need more blood. A antagonistic hormone of essentially any of the hormones in this process is what we call ANP, which stands for atrial natriuretic. So this blocks renin. Okay, go back and look at here. Renin is the first part of this system. So you have to have renin before you can have aldosterone be produced. So if you're not producing aldosterone, you're not going to be retaining salt and water. Therefore, the blood pressure is going to go down. It's actually made by the heart when blood pressure is too high, hence the atrial. Okay, so let's talk about this system. As we said, what stimulates the system is what stimulates the production of aldosterone, which is going to be a low amount of blood volume, which again, the volume of blood directly reflects blood pressure. So if I have low blood volume, I'm going to have low blood pressure. When would you have these situations? Okay, if you're very dehydrated, whether it's from not drinking enough water, vomiting, diarrhea, consuming too much alcohol, or hemorrhaging, losing internal bleeding, losing blood. So low blood pressure is going to stimulate in the kidney. There are these specific cells called the juxtaglomerular cells, which for right now, you don't have to be super specific about those because we're going to talk about that with the kidney. Basically, I want you to know that low blood pressure makes cells in the kidney secrete an enzyme, which is renin. Okay, so remember, an enzyme is going to catalyze or speed up a reaction. Okay, so renin is going to convert something that we already have in the blood, a plasma protein, which is called angiotensinogen. And one thing you're going to see that's kind of a common theme is when things are in their inactive form, they're going to end in ogen. Okay, so the inactive form is basically made in the liver. So when renin's produced, the angiotensinogen becomes angiotensin 1. Angiotensin 1 moves to the lungs, and there you have an enzyme in the lungs called angiotensin converting enzyme. For short, we use ACE, that will convert 1 to 2. 2 is what, angiotensin 2 is what stimulates the adrenal cortex to make aldosterone, which we know, of course, the effects of that are that we're going to reabsorb salt, which water follows directly, which of course is going to increase blood pressure because we're increasing blood volume. Okay, but it also can increase blood pressure because it makes your vessels constrict. Okay, so if the diameter of my blood vessel was that, with angiotensin it becomes smaller. Smaller space for the same amount of blood is going to increase your blood pressure. So you can have hypersecretion of aldosterone, which basically means too much. The problem with that is that it can lead to hypokalemia. You don't have enough blood potassium levels because remember, aldosterone lowers the amount of potassium. If that's too low, that's going to have negative effects on the nerve and muscle contraction as well. It can lead to too much sodium, hypernatremia, which again, sodium potassium levels affect neurons and muscles. And if you have too much sodium, you're retaining too much water, so it's going to cause high blood pressure, which the more technical term for that is hypertension. Hyposecretion will be discussed a little bit later in the presentation. Okay, other hormones of the adrenal cortex, we have glucocorticoids, which are made by both the fasciculata and the reticularis. This helps us to regulate our stress response. Okay, the most potent, strongest glucocorticoids are cortisol, which is also hydrocortisone. When our body is stressed, the homeostasis changes. We need to increase the amount of blood glucose levels when we're stressed, okay, because our cells are more active. So acute stress, short term, will increase the amount of cortisol and epinephrine, which of course you feel that in your heart, the stress. Chronic stress, you won't have the epinephrine, you will only increase the amount of cortisol. And again, there's more on this if you look at one of the later slides. Okay, so stress response. Cortisol makes liver cells synthesize enzymes involved in gluconeogenesis. We actually discussed this already. It's making glucose from non-carbohydrate sources, okay, amino acids and fatty acids. But you're still increasing the amount of glucose, which again the body needs. Cortisol also is going to break down proteins in skeletal muscle. Okay, proteins, of course, the building block of proteins are amino acids. Amino acids can be converted to glucose. The problem with this is you really don't want to be breaking down a lot of muscle. That's usually not a good thing. So that's one reason why it's important to regulate the amount of stress in your body. We also said epinephrine, that's going to affect your heart. So stress is really important that we can try to regulate this because it does affect so many different ends of the body. Cortisol also acts on fat cells, adipocytes. It's going to make them release the fatty acids that they have, again, so we can convert it to glucose. And we actually have cortisol receptors pretty much spread out throughout the body. So it's widespread, and cortisol is a steroid hormone, where steroid is lipid, which means the receptors are going to be located inside of the cell. Cortisol, when produced in high amounts or even for a little bit longer period of time, is anti-inflammatory. So it actually is going to decrease the activity of several of your white blood cells, leukocytes, therefore decreasing your immune response. Okay, especially if you're taking steroids given to you by the doctor. Okay, so that's what we mean by pharmacological doses there. A steroid pack, multi-dose pack. What does that have to do with final exams? What that means is when you're really stressed with final exams, your immune system is decreased, and it's not uncommon for students to get sick, okay, after final exams. Okay, so regulation of cortisol is going to involve the hypophyseal, portal, adrenal axis system that we discussed previously. So again, first here is going to be the hypothalamus. CRH is made by the hypothalamus basically at a rhythmic fashion, meaning constantly. Although we have the peak amounts of those made in the morning. So CRH makes the anterior pituitary release ACTH. Of course, we're going to have more ACTH in the morning. So that's going to stimulate the cortisol production of the adrenal cortex. So that means during the morning, because you have more cortisol, your glucose levels for blood are going to be elevated. When you have more cortisol, of course, that's going to cause the negative feedback, so it will stop making you produce more than what you need. So this is just a really great figure that puts all of that together, kind of diminishes all the wordiness, and can help you try to get each step involved. Remember, with all hormones, we're basically looking at all of these components. The only difference being you won't always have the third tier control. You're only going to have that with tropic hormones. Cortisol disorders involve either producing too much or you're basically being administered by a physician long-term use of corticosteroids. So you can develop Cushing's disease, which is when the adrenal cortex does it. This is from a tumor, so you have an overgrowth of tissue, therefore it secretes more hormone. Also, iatrogenic Cushing syndrome is caused by not your adrenal cortex actually making too much, but being administered cortisones for too long. So typically that one's obviously stopped once you stop the cortisol administration. It doesn't matter if your adrenal cortex is making too much or if you're being given too much. Cortisol causes lipolysis. You might think that's good. If I'm breaking down fat, I'm losing fat from the body. Unfortunately, we're getting rid of the fatty acids from your arms and from your legs. So those become smaller, but we're going to deposit more adipose tissue around the trunk. So you'll have like an enlarged stomach, gut area. You might have more fat on the back, on the face. They call it a moon face. You get a very round face. On the back of the neck, they call it a buffalo hump. So those would all be signs of a person producing too much cortisol. Okay, so how they say stress ages you. Striae of the skin are basically stretch marks. So cortisol stops fibroblasts from being able to make the collagen and elastic fibers. Therefore, the skin is less elastic or pliable, and the dermis and epidermis tears, and that's how you get those bad stretch marks. When you break down your muscles too much to use the protein to make more glucose, obviously your muscle strength lessens. So the amino acid gets converted to glucose, which makes us have too much glucose in the blood, a high level, which of course is what we call hyperglycemia. So small amounts of mineralocorticoids can cause hypertension, high blood pressure. They are going to suppress the immune system. It's also actually going to decrease the effects of osteoblast, which mean that you're not going to be storing as much calcium in bones, which is going to make your bones weaker. So again, stress wreaks havoc on the body. So this is a person that's developed Cushing's syndrome. So because they have so much cortisol, they've gained fat. Obviously you can see around the face they have the moon face. Can't see everything here, but you could tell, like, the midsection and stuff has gotten a lot older as well. So basically, when a doctor asks you when's the last time you've been on a steroid, that's really not something you want to lie about. Or if you're in a lot of pain and your doctor's response to that is just to keep doing steroid injections or pills, that's really not a good long-term solution. So when the adrenal cortex is unable to make as much cortisol or aldosterone that are needed in the body, this is commonly causes Addison's disease. This can be very serious because aldosterone helps regulate the amount of electrolytes, sodium, potassium that are in our body. Therefore, water that's being kept too, so your fluid electrolyte levels get messed up, and your acid-base balance because of potassium and hydrogen as well. Those are definitely going to put your body in a crisis mode because it's unable to regulate the homeostasis. Many causes of this can be that the adrenal gland did not develop properly. You don't have enough enzymes to actually make the steroid hormones. There's several steps of that involved. Or your own immune system has attacked the adrenal cortex, and therefore it can no longer secrete the appropriate hormones. Androgenic steroids are the last type of corticosteroid. They're produced by the zona fasciculata, which is the deepest portion of the adrenal cortex. These, again, are in very small amounts. So testosterone and estrogen that actually bring on secondary sex characteristics, we're not talking about them being produced by the adrenal cortex. Okay, we're talking about those being produced by the gonads. And a lot of times what happens is from the cortisol, your body can try to start converting some of that to other corticosteroids, meaning these androgenic steroids. Usually these are going to be androgens, which are typically a male steroid. However, our body can convert testosterone to estrogen. So you can end up having a disorder in that a female is having testosterone produced here that are going to give her more manly characteristics, and the male can end up having an increased amount of estrogen, okay, which is going to give him, we call gynecomastia. It's a lot of fat and adipose tissue around the pectoral region, who actually can develop breasts. Okay, now talking about the adrenal medulla, the cells that actually make the catecholamines are called the chromaffin cells. Technically, there are two catecholamines or adrenalins. They include epinephrine and norepinephrine, although there's way more epinephrine, about 80% epinephrine versus norepinephrine. And acute response to a stressor, you will release a little bit more of this. Remember, we already talked about that. And that's one reason why your blood pressure can be increased. Okay, when you're stressed, you're going to have more sympathetic response, more cortisol increases blood pressure as well. So if your heart's working harder, it's going to be pumping more blood out. Your bronchioles in the lungs, which are smooth muscle tubules, dilate, which basically means it's easier to get oxygen into the lungs and therefore into the blood. They're going to constrict blood vessels that supply organs that don't really need to be working, okay, during sympathetic mode. So the skin, they're going to constrict digestive organs, urinary organs. This is one of the things when you have constriction, it's going to increase the blood pressure. We're going to dilate blood vessels serving skeletal muscles. Okay, skeletal muscles are going to allow for activity. And again, with sympathetic epinephrine, that's the response that you want. You're going to have the dilation of pupils so you can see threats coming from a distance. And of course, you're basically going to stop digestive and urinary activities. So the adrenal medulla, because it's an endocrine gland, it's going to release epinephrine everywhere. Okay, so anywhere you have an epinephrine receptor, you're going to carry out a response. Epinephrine or catecholamines can also be released locally at a site, okay, by an axon terminal. So basically what it's going to do whenever you have it just being released at a site, it's going to increase the amount that's released locally. Keep in mind though, you don't actually have to have sympathetic nerve fibers going to every organ that you want to have a sympathetic response, again, because in the bloodstream by the adrenal medulla, it can go anywhere. So ACTH stimulates epinephrine release. Okay, although its primary effect is the adrenal cortex. Okay, cortisol causes epinephrine release. So basically what we're seeing here is a coordinated response between the endocrine and nervous system. The two systems that are helping regulate homeostasis. In this case, the best thing for you is to remove yourself or defend yourself, if you're in sympathetic mode possibly, from something that could be fatal. Okay, so it enhances, okay, your chance of survival. Okay, so this table just describes all the stuff we talked about, kind of puts it in a little bit different forms. This is a lot easier for some people to study versus just looking at it on the slides. So when you stop taking steroids that have been given to you, you'll typically notice that the steroids will be tapered off. You don't just want to, be taking 7 in one day and then all of a sudden just stop. That's because of the negative feedback loop of the HPA axis system that controls cortisol production. So basically when you're given corticosteroids for a long period of time, your hypothalamus sees that the amount of cortisol has been increased. So it's going to stop doing the cortico-releasing hormone, which stops producing ACTH. We call that HPA axis suppression. The problem is this occurs for several weeks or months after you've stopped the therapy, which can put the patient in danger. It basically hinders their body's ability to go to that stress mechanism and to be able to appropriately have a sympathetic response. Most serious consequences of the suppression is adrenal crisis. Basically, cortisol you have to be able to survive when you're stressed. If your body cannot respond to stress adequately, then you will have very low blood glucose. You're going to feel fatigued. Your blood pressure is going to be low. That will also make you feel fatigued because your cells are not getting enough oxygen. So it's really easy to faint. You might vomit, convulsions, where you can't really control muscle activity can occur as well. If this is not treated when you start to have these symptoms, it can be fatal. Now, of course, it can be prevented by if you start giving them corticosteroids again, small amounts of time, and just until you allow their body to be able to make the cortisol again. Okay, so if we're doing review, it's asking which of the layers of the adrenal cortex is matched correctly. The reticularis does do androgens. Remember, it also does do cortisol. The glomerulosa actually does aldosterone, where the fasciculata does cortisol. So those two are mismatched. Okay, the adrenal medulla has tissue similarities with parasympathetic ganglion. That's false. It has similarities with sympathetic ganglion. Okay, remember the adrenal medulla releases epinephrine, which is a major neurotransmitter hormone of your sympathetic response. People under a great amount of chronic stress are no more prone to disease than those who are not. That is false because, again, chronic means long-term. Long-term amounts of chronic stress are going to increase cortisol levels, and that's going to suppress your immune system. So yes, it is easier to get sick.